Thank you. So my name's Dr. Hume Rendle-Short. I'm a GP in Toowoomba. And this afternoon I'd like to talk about, leadership as a general practitioner and what I call making the call. And to illustrate this, I'll just quickly run through a case that came through our practice about a month or so ago. This was a nursing home patient, very elderly, 86 or something, being looked after by a junior registrar, and that's fine. And given this case, it was a learning exercise for that registrar, and he did very, very well in the whole case. But basically, what happened was he correctly diagnosed cholecystitis in a patient who obviously was unwell with that, with fevers and right upper quadrant pain, raised liver function tests. And I don't know whether I would have done a CT, but he did a CT and there was a diagnosis staring us in the face. And then the question was, okay, what on earth, what are we going to do about this? We've got the diagnosis, how are we going to manage this? With the background, the patient had probably mild to moderate dementia, was sort of a happy wanderer, wandering around the ward normally, but certainly unable to give details with respect to her where she was or anything like that. So the first question was whether we should admit the patient or not, and we had some discussion with myself and the registrar, and the registrar had some discussion with the nursing home. That's what my advice was. You need to talk to the home, you need to find out a bit more about the patient, about their normal functioning. Certainly had some discussion with the family, which was a daughter and son-in-law in Melbourne. There was another daughter also living in Melbourne who we never made contact with for reasons that sort of became clearer as the case went through. So he had some discussion with them, and the family wanted to know what was going on, and we knew what was going on, we had a CT, but they wanted to know what was going on and what the prognosis was. And I don't know about you, but my training has taught me that, and my experience has taught me that a fully blown cholecystitis in an elderly patient basically has to have surgery. If they don't have surgery, then they probably won't make it. And so that's where we were up to. And the question was, do we refer to the hospital for surgery or not, or whatever? And interestingly, I sort of, we talked in and around it, etc., and I was quite strongly, or moderately strongly, on the idea that, let's start from the end point. Are we going to operate? No, we're not. Okay, so we worked that out. We worked that out with the family, and we were all comfortable about that. So if we're not going to operate, what are we going to do? And there was a bit of pressure from the family to get a surgical opinion, and so to confirm that decision that no, we're not going to operate, and what are the other options. So we did, and the surgical opinion was, well, I need to see the patient, and for me to see the patient, I need them in hospital. And that's where things started to become interesting. So we were sort of started to get locked into this pathway that said, okay, this patient needs to go to hospital, which they indeed did, private hospital, and was admitted on the Monday, I think it was, sort of late-ish afternoon, under my name because the registrar didn't have admitting rights, another story. And so we had this patient there, and I said, look, I'd sort of see them in the morning and we'd take it from there. Things started to deteriorate at night, about 10 o'clock, and the ward was becoming uncomfortable because she was in fact deteriorating, and I ended up going up to the hospital and visiting her. And the reason was because the ward was basically saying, this lady is deteriorating, we don't have a signed not for resus order, and we have called a Met call and called ICU in. So ICU were now saying, what's going on with this lady? So I got up there, and she had deteriorated dramatically. She was unconscious, febrile, her breathing was okay, but yes, she had deteriorated rapidly. And which, to be honest, is probably consistent with the clinical course of the condition untreated. And so I had the hospital and the nurses breathing down my neck, and then the ICU guys talking to me and saying, you know, what's going on here. And I made another phone call, which was in fact the first time I had talked to the family, through to the family, and laid it on the line, and we came to the decision that we're not going to operate. And so if we're not going to operate, then my decision was, okay, then we're not going to treat. We're going to regard this as a palliative situation, keep the lady as comfortable as possible, not embark on antibiotics, and certainly not embark on an ICU call and resuscitation, etc. I made the call, and fortunately, I guess, no, not fortunately, I guess, sort of pleasingly, the surgeon the next day endorsed my call and said, no, that was right, and he was comfortable with that. And so we were able to let this lady have a relatively peaceful death that lasted a further 24 hours. And she indeed did die, which was the anticipated outcome. It was interesting in retrospect, though. The family in Melbourne were putting some pressure on this situation, and it wasn't until retrospect that I realised the significance of that, when the daughter, there was a husband involved who also had dementia, who lived at home, and the daughter said to me quite explicitly, don't tell my stepdad, the husband, that I was involved in this decision. And there was a history to that, and she didn't want to, within the family, be the one who had made the call. I was happy to take responsibility for the call, which I did, and I believe that it all ended relatively okay. But I guess it's just an argument for the need for us as GPs to look at the whole situation and make the call and make that decision and help the family in that process. Thank you.